right? Because I really want this to be more of a training space as opposed to, trying to like be a great diagnostician in the next 8 weeks. Because that's not going to happen, and then you don't really gain much by just being like, oh, I got it, it's borderline, oh, it's bipolar. Like, that doesn't do very much. So as we get closer to that, that's gonna become clearer to you guys how that's gonna look. We're also gonna do some more practices of those in the classroom too. Some of this for some of you guys is gonna feel like a little bit like vague. It's gonna be like, I don't know, am I doing it right? Am I not doing it right? And it's gonna be up to you to know how much effort you put in, and then it generally comes through. Meaning, like, if you kind of like half-ass it and you're like, you just write a bunch of observable things, like, I'll know, right? And that's really the truth about, I would say, our profession, but anything in life, is that, like, the work you do behind the scenes is going to make the product really good, and people will know if the product is good, then you did the work behind the scenes, and if you half-assed it behind the scenes, like, people feel it, people see it, right? They say about comedians make their money at night, during the day, but they collect it at night, right? That's because they're sitting and writing jokes and trying to tinker with the material during the day. And then they tell one joke, they get a huge laugh, and then they get a payday, right? So it's the same idea here. When you take a look at a case that we're working on, so don't be ridiculous about it. Don't overstress yourself and put in 150 hours into an assignment, because that also, I would say, is coming from a strange place, because nobody's asking you to do that, right? But be thorough and be committed to it. And that's going to be the way it is in your profession, and honestly with everything you do in life, right? Because with everything, and I really learned this when I went back to school after my master's degree, it's you got to do you got to be thorough in your own areas. Mm-hmm. Meaning, like, required reading is something that, like, almost sounds funny to me at this point, because it's like, if I want to be good at it, then I'll read every single thing that exists on the topic, right? So, like, doing it because it's a requirement, like, sometimes you have to do it because it's part of a direct assignment, right? But other times it's like, is this something that is valuable to you? Or are there other sources of material that you want to look for on your own, right? Because that really is how you become an expert in anything, right? You take a topic and you drill down on it so far, in theory, in history, in every direction. We're going to talk a little bit about that tonight too, because it's relevant to our topic. But then it's up to you to decide how much you want to learn about that specific disorder. But remember that facts, clusters, and theories is going to lead to diagnosis, and diagnosis is the last step. And this is one of the things we're going to talk about tonight, is that diagnosis being the last step, because you cannot observe symptoms and then say what someone has with a mental disorder like you could with a medical disorder. It's very, very different. So if you were to say that this person has a combination of a fever, rash, and a cough, and that makes me say that it's influenza, right? So your theory is not really as flexible. I'm jumping ahead a little bit, but your theory is not going to differ so much from one physician to another, right? You could have one person. I saw somebody online last night, not a mental health professional, but a nice little hullabaloo broke out. She posted, "I don't believe in anxiety." So she doesn't believe in anxiety, and she's a coach or whatever, right? And then you had all these psychoanalytic psychiatrists that were like ripping her to shreds, right? But she still doesn't believe in anxiety, whatever that means. She doesn't believe in anxiety, right? That doesn't exist when we're talking about, let's say, a medical issue. Unless, there are obviously fringe opinions, and there could be, Eastern medicine and extreme differences in opinion. But typically, somebody sees those constellation of symptoms, they kind of go, this is what it seems like it would be, and this is the prescribed intervention, right? While in our field, when we're dealing with psychology, soft sciences, however you want to call it, one person could see anxiety with an anxiety disorder, that's an anxiety disorder, and the best course of action is medication, and someone else could say, there's no such thing as anxiety. Mm-hmm. Right? So that's why we're going to drill down on the different parts of what we're observing. Is there a pattern that we're observing? Because that's clusters. Clusters is pattern. right? And then what's my theory on the significance of this behavior, of these patterns that I'm seeing? And then therefore, I would say that it fits this diagnostic category. Does this make sense? Mm-hmm. Yeah? Getting into our topic tonight, we're talking about assessment. Now, this is a very broad discussion because we could be assessing for lots of things when we're talking about mental disorders, psychological disorders. But we're going to talk about some of the main pieces of assessment, like what we're looking for to understand if a person has a disorder or doesn't have a disorder. And like always, you're going to hopefully walk out of here with more questions than answers, but that's good, right? Because questions can lead us to clarity. Don't forget that. Questions can lead us to clarity. If you have the answer to something which is very complex, like that, you probably don't have clarity on it. You just have a lot of comfort in thinking that you have the right answer, right? So I think about this all the time. This was several years ago. I had an intern that we were working on a case where there was depression involved, and I wanted to flesh out the case. I wanted to explore it. I wanted to look at it from different angles. And she said, well, clearly he's depressed. And I said, okay, so therefore what? And I was being annoying to her, right? Therefore what? And she said, well, then we need to treat it with CBT. And I almost exploded because I was like, how are you conceptualizing depression and how are you conceptualizing CBT? What is CBT? If it's a behavioral, if you say that you need a behavioral intervention, then I would challenge you to explain to me the theory behind your understanding of how this is a behavioral disorder, right? Because a lot of people would say that depression can be just a chemical imbalance, right? And that it could require a medical intervention. So if somebody's going to say that it requires a medical intervention, why are you treating it with cognitive behavioral therapy? So if you reverse engineer what she was saying to me, she was basically saying that I view this case through a behavioral lens, right? Which I'm fine with. But I wanted her to explain it to me. And at that time, unfortunately, she couldn't explain it to me. Meaning that she wasn't thinking very deep in terms of her diagnosis. She was just kind of going, label, put it, we got it. Cool, I'm smart. She was smart, but she needed to. Right, so when we talk about assessment, there's a lot of different settings and a lot of different pieces, and we're going to get into all of it tonight as much as we possibly can. But it is very, very complicated. Again, different than a medical diagnosis. You look at somebody and you see something which is an observable fact, and then that leads you to potentially these 5 disorders, and then you look and you find another fact, and then now it's either this or this, right? And the treatment for both of them kind of is the same, or the treatment for both of them, one of them is harmless and it might work, so we'll just do that one and see from there, right? When we're dealing with mental health, one could argue that the normal way that someone is living is a mental health disorder. Someone could make that argument, right? Which is kind of wild. Now, here are 4 things that you can't observe, which you need to understand in order to diagnose somebody with a mental illness. Okay, so 1 is you cannot observe someone's feelings. You cannot observe someone's thoughts, their intentions, or the meaning behind something. So let's look at the first one. Can we observe someone's feelings? So I say no. Does anybody disagree? No? Someone play devil's advocate. Yeah.
Hypothetically, you could be doing a CT scan and see where in the brain it activates certain regions while they're expressing things.
Okay. Interesting. All right. Anybody have? Okay. Yeah.
Not really realistic.
Yeah.
Energy vampires.
Did you say energy vampires?
Yes, they know.
Is that a
how
thing?
they feel it.
I know about regular vampires. I don't know about energy ones.
Well, people that, I don't know, some people just feel your energy, just bring it down.
Okay, so interesting. You can feel energy, and there's truth to that, and right? And at the same time, you cannot really observe someone else's feeling.
You can't really see.
Right? So if you were experiencing someone else's emotion, right, whether you call it energy or whether you call it just, your let's say you go neuroscience, you call it mirror neurons, you call it empathy, whatever you want to call it, right? I'm influenced by your emotion. Does that mean I can observe your emotion?
No.
No. What do you say? Okay, so if we say that observing something which is commonly associated with a certain feeling, so to be really annoying about it, I would say we still haven't observed the feeling, right? What did we observe? Right, so the reaction to a feeling or the behavior that is associated with a feeling, and so that means that we are interpreting that behavior to mean that it's associated with this feeling. Now, that is part of what we're doing, right? As mental health clinicians, we are interpreting behavior, and we are saying that it might indicate that this is there, it might mean this is there. However, if you think about it in a very, very technical way, you cannot observe someone else's feelings. Right? So we do this all the time where we're like, he's angry at me. How do you know he's angry at me? Because he was going like this. Right? Can you see that he was angry at you? Right? If you were to say, I have evidence that this person's angry at me, and your evidence was only their eyebrows, I would say that's weak evidence. Right? But we get them crossed. Observing someone's feelings and observing behaviors which are highly correlated with certain feelings are not the same thing. Okay? Thoughts are the same thing, right? So we can assume that somebody is thinking a certain thing when the reality is that we cannot actually observe it to see that this is something that exists. Right? And this is very, very important because we are looking at somebody who is, let's say, coming into our office, and we have to understand what's going on in their world, how they tick, what the problems are, what the strengths are, all that kind of stuff. And feelings and thoughts are obviously a major part of the psyche. So if we can't observe them, we're going to have to be really, really careful that what we are observing is accurately interpreting, right? That we're making an accurate interpretation of the behaviors or expressions, and saying it seems like it's correlated with this, or that it's linked to a feeling or a thought, right? Intentions are another one. This is a good one. This list actually comes from DBT. I don't know how many of you guys are familiar with DBT, but I used to do a lot of work with dialectical behavioral therapy, and this is one of the modules. And this is very interesting because when treating people with emotional dysregulation, so there's oftentimes a perception that something was thought or felt about them, or that there was intention that is associated with a certain action, and then the dysregulation that comes after that is really based off of a faulty interpretation, right? So I see two people whispering to each other, and then they look over at me while they're whispering, and I go, oh, so they're talking about me. And they're talking about me because they hate me. And then I go over to them and I confront them. And I'm like, what's wrong with me? And they're like, what the hell are you talking about, right? So this actually being from dialectical behavioral therapy, when somebody has a disorder that has dysregulation attached to it, and I would even say if somebody is a human person, then this is a very helpful list, right? Because we think that we're observing this stuff, and we are never observing it. And there's room to maybe question whether we were right about it or not. Right? So my partner, I used to have a practice. My partner was a DBT specialist, and she would always refer back to these. And this is part of the module. If anybody's familiar, it's called Check the Facts. Right? So you're helping people check the facts. What are facts? Right? Same like we do with facts plus some theories. Right? It's observable fact that guy in our video last week had a mustache. It's not a fact that he feels a certain way or that he thinks something. Right? Okay, so intention, right? This is something that we cannot observe. Now, somebody can say, this is my intention, or I'm doing this because of this, and that is valid information. We're not going to just toss aside things that people say to us. That would be silly. But we cannot see the intention that somebody has behind something. All right? Words, and we're going to talk about this a little later, words are symbols. And if words are symbols, they represent something, and it's limited. Right? Like, it's hard to communicate with somebody if you were just sending emojis back and forth. Right? Because, well, what does that emoji mean? right? And I assume it usually means a penis because it's like, most of them are like, everybody's like, oh, you can't send that one, right? But you have pictures that represent feelings or ideas or words. And if you just tried to communicate with somebody using those pictures, it would be really, really difficult. Words are the same way. It just happens to be that we're a little quicker with it, and that we're used to it. So if somebody says to you, I'm really anxious, you have a framework for that, right? If somebody says, I'm really pineapple, you're like, I don't know what you mean by that, right? And they would have to explain it. So when it comes to intentions, so we're going to, and with all of this, we're going to listen to the words that our clients are saying. We're also going to understand that there is a limit to how much we can understand what's in their world, right? So you have your inner world, I have my inner world, and mine lives behind here, and yours lives behind there, and then we have this shared space. And in the shared space, we try to communicate what it's like in here, and you try to communicate what it's like in there, right? A really good example of this is if you've ever had an amazing experience somewhere, and then you try to tell somebody about it, right? Like you went to like a concert or like a sports game or like on a vacation, and you're like, it was amazing. And they're like, yeah, tell me about it. And you're like, it was just so good. And they're like, yeah, like what was it? Like when you walk out there, you see the whole thing, and it's just so, oh man, it's awesome. Like there's a limit to the amount you can share your inner world with somebody else, right? Because the words don't do justice for the feeling, and the feeling is something that the other person can never observe. Right? Alrighty. So, in general, when we want to talk about somebody being grounded in reality, we want to talk about them being oriented to the reality that we're living in. And the orientation to these four factors is oftentimes our way of assessing if there's a larger mental health issue, right? This is a really, really helpful thing, and you'll see this, and if any of you guys work in treatment centers, you have to oftentimes write on forms, he was oriented for X. Has anybody ever written that? Yeah? Right? So what that actually means, right, because a lot of stuff we have to write is sometimes not explained. What that actually means is, do you know what day it is? Do you know what day it is? Do you know what's going on right now? Do you know where you are, and do you know who you are? Right? Those are typically questions that if you can answer them, you're within the realm of a regular functioning person. If you can't answer them, so then that's concerning. Right? So somebody with an anxiety disorder will likely be able to answer all of these. Somebody with a schizophrenia spectrum disorder will likely not be able to answer all of them. And maybe sometimes none of them. Right? So tell me who you are and where are you, what day it is. It's 1976 and I'm Bruce Springsteen and I'm about to go on stage. Like that's a real thing that will happen when you're working with psychotic patients. Right? So this is the basis. This is the basis, right? If you're going to say, all right, so this person is oriented to all four of these categories, so then we can kind of move into more nuanced and more detailed type of assessments. Does this make sense? Mm-hmm. Any questions? No. Yeah.
By oriented, you mean the person is able to provide an answer.
Yeah, right. So like oriented, like you're connected to it. You're grounded in it. Right, because these are things that are part of our basic ability to function. Mm-hmm. Right, like the way that we conceptualize time makes us able to accomplish things. It makes us able to relate to other people. Do things with other people. Mm-hmm. You're disoriented if you were in an accident or something like that, and you have like a head trauma, and you don't really know what time it is and what day it is, and right, like you're not in touch with your body's cues, the world's cues. I don't know if you've ever been on like a really, really, really long flight. You could be disorienting, where you're kind of like, I know that like we're 11 hours into the flight, but like I'm not living my life connected to the same time and space that I normally am, right? And you're kind of like, it's nighttime, I guess, right? And knowing who you are, that's also right. Like like we could take that for granted, but if you think about it, everyone in this room at one point in their life, for a good couple years, did not know who they were. Because you didn't know that you were You didn't know that you were. There we go. You didn't know that you were, meaning that as a baby, you're not oriented to who you are, right? So, think about that. Like, knowing who you are is something that we kind of take for granted because we generally do know who we are. But imagine that piece was missing. Imagine you thought you were someone else. It's pretty wild, right? And if any of you guys work in like deep end psychiatric care, you'll see that. You'll see people who are completely disoriented when it comes to who they are. Right? All right. So that's number one. Now number two is when somebody comes in and they have a complaint or a presenting problem. We're going to look at these three areas: frequency, duration, and magnitude. Because like we said last week, every one of us have anxiety. But that doesn't mean we have an anxiety disorder, right? Every single one of us gets sad, but that doesn't mean that we have a depressive disorder, right? I get messed up every single year from the clock change. Like, I'm a big advocate for lock the clock. Like, I'm like a psycho with that a little bit. But like, it's enough already. But part of the reason why it messes me up is because when I grew up in New York and we would change the clocks and it would get dark at 4:30 and it would be cold and we couldn't go outside, that was a very sad time of year for me. I would feel very, very sad about that. Now, when we're in South Florida and all of a sudden it's dark at like 5 o'clock and it's not cold outside and it's not the same life that I live, it still does something for me. And I go a little bit like, right? That doesn't mean I have depression. It doesn't even mean that I have seasonal affective disorder. I don't really even know what that is. I mean, I think that's just, you're sad because it sucks. I don't know, like has anyone here lived in the cold for yeah? You lived in, right? When you live in the cold, it's kind of a bummer. I personally wouldn't call it a disorder. I'm like, if in the whole Northeast, Northwest, like Midwest has disorder. It's rough. It's rough to live in the dark and in the cold, right? So with certain human experiences, we're going to say, how often is this happening to you? Right? Because something that happens occasionally does not, right, is very different than something that's happening daily, hourly, something like that. Right? Like, I will cry when I watch Toy Story. I just will, and I have no say in it anymore. Especially once you have kids, like, the cliche is true, you can cry from a Geico commercial. That doesn't mean that I'm sad all the time, right? How often is this happening? If I were to say that every single time I see a TV that's on, I start crying, that's pretty significant, right? That's frequent. So we want to know about frequency, right? We want to know about duration, right? So let's say I cry from Toy Story, and then I don't stop crying for 6 hours. So like I'm flipping through the channel, and then I just see, there's a snake in my boots, and then for 6 hours. That's too long, right? Meaning that's too long where I would say that this might be an issue. This is outside of the norms in terms of functioning and ability, functionality, right? And then the magnitude of it, right? So if, again, we'll go back to the Toy Story example, like let's say that every time I see Toy Story, but it's only Toy Story, it bums me out for like a day. But the level of it is kind of like not that significant. End of the day, I'm okay. Right? Kind of like when we change clocks. Right? Like, it can be frequent and it can be a long duration, but if it doesn't really disrupt my life, right? It's not changing me and disturbing me. So then I could see us saying, or me saying, yeah, that's hard. I'm sure that's very, very hard. Doesn't mean we have a disorder on our hands. Does that make sense? Mm-hmm. Any questions or thoughts about that? Let's go, guys. Everybody's happy with it. Everybody's like, Oh, thank you. Thank you so much. Oh, that says the same thing. All right. So I'm going to, one second. I'm going to go to here. I'm going to go a little out of order here. All right. So right now what we're doing is we're setting the kind of the basis for our diagnosing, right? We're talking about orientation, and we're talking about frequency, magnitude, and duration. Now, quickly, medical history is very relevant, right? Because can you imagine a medical issue that could cause a mental issue, right? And you can imagine a medical treatment for that medical issue clearing up the medical issue and the mental issue, right? So you got to know, is there a medical history here, right? And a lot of the stuff, I'm giving an overview here, but I believe I posted the mental status exam. Did I post that? Yeah. Yeah, so the mental status exam, typically wherever you work, there's going to be questions, like intake questions, and there'll be a few questions about a medical diagnosis, a medical history. Right? It doesn't have to be in great detail, but you do want to know if somebody has some sort of a medical issue, either that's ongoing or that is relevant. It's from their past, but is relevant to now. Right? So, like, what would be an example? Let's say of
High blood pressure.
Okay, good. So if somebody has high blood pressure and they're coming in, what would you associate with that if you had?
Depression.
Yeah. Okay. Right. What else? Any other thoughts on that? A medical issue that could be associated with mental distress.
Like chronic pains.
Chronic pains, right? Which is going to get very complicated because some people will say the other way, right? Some people will say that that's not even a medical issue, right? Could be that sometimes it's more of a psychological issue. A somatic issue, if you will. Any other thoughts, right? Think about it. If somebody came in, let's say they came in and they were very, very anxious. So what medical condition could be associated with anxiety? What'd you say? So that would be a mental, right? So that would be a mental disorder, which is within our scope. But like, let's say a medical illness that would potentially cause anxiety. But like, think medically. Think like what you would go to a straight up classic physician for.
Can it be something like infertility or?
Okay. Right. So, okay, let's go with infertility. If there was an infertility issue, maybe there's medication which is increasing. Right? Maybe there's hormone changes based on the medication. Like, that's a good example. Because I actually like that example because I'll come to you in a second. Because it's actually 2 steps removed. Because you might be like, are you going through any medical issues? And you could hear infertility and you're like, well, I don't think that has anything to do with what's going on. But what about the medication? Right? Are these medications associated with, elevated central nervous activity and, higher stress and anxiety? Right? Maybe, because sometimes people will take a medication that they need for a medical issue, which then exacerbates a medical issue. Yeah, mental issue.
I would say probably medical issue for anxiety is probably like gut health, so like
Yeah.
GI.
Yes. So those two are very linked,
Yeah.
right? And I work with a lot of people who have Crohn's, colitis, like that, comes up very often. And it's very interesting when it's chicken or the egg, right? Because then there's a conversation, like we were saying before, like somatic stuff, right? Which you'll learn more about at different points. Like, the body kind of like absorbing the psychological stress to the point where it turns into a medical issue. But is a medical issue required first? A medical treatment, rather. That's the question, right? Meaning if somebody comes in and you think that you have a good conceptualization where you're saying, this seems like it's psychosomatic and we're going to do some therapy and I'm trained in a certain modality which can help release certain feelings from the body. But what if the person needs actual medical care first? Right? We have to be smart about that. Right? There are times where we go in the other direction. Like, I work with a lot of males who have erectile dysfunction. Their erectile dysfunction comes from anxiety and watching too much porn. That's where that comes from. But they want to go to a urologist, and I'm like, go for it, man. You'll be back. You'll be back. You'll be back. Yeah.
With like nutrition, I've worked with some clients and they're college students and they all have anxiety. They're drinking Red Bulls, they have coffee. That would that fall under more medical?
So it's relevant. it's relevant, and that's where we come to. Well, we'll keep referring back to this slide, but noting things for later, right? So, if somebody, let's say, comes to you with a lot of anxiety, and they're drinking a lot of Red Bull, it's a nice link there, right? And at the same time, there could be other factors which are much more relevant, because there are some people who drink a lot of Red Bull and they don't have anxiety. Right? And it could be also that this person's anxiety is just getting amplified by the Red Bull or whatever the Celsius. I had 1 Celsius one time, and I was up till 3 in the morning. I got nervous before a presentation. I was like, I need some caffeine. And I drank a Celsius, and then afterwards I was like, what the hell is going on? And my presentation was over at like 8:15, and then like I was like, what do you guys want to do now? You guys want to go out to eat? You want to get some food? You want to get some wings? Yeah, it was crazy. Those drinks are kind of nuts. And at the same time, right, we're not going to just like say that's the whole conceptualization of the case, because there could be much more there, right? Anxiety is going to be a really tough one in today's world, because anxiety is something which, again, in my theory, everyone has anxiety, some level of anxiety, right? But there also is anxiety that's kind of coming out of the way that we're talking about anxiety. Like on the way here, I was listening to a podcast I just randomly clicked on, and it was about the first session in therapy, which there's been extensive writing books just about the first session, right? And the lady was asking the other person on the podcast, because it was supposed, I think it was more for like just like general education, general population education about what therapy is and what you should expect in your first session. She asked him, can a therapist write a note to get somebody, let's say, to give them a mental health day, where they would have to, they could say, my therapist wrote this and therefore I'm able to miss school or able to miss work or something like that, right? And the guy said back to her, what would be an example where you would need to write that? Because I'm thinking that if you need to take off from work, then you probably have a more severe issue that needs like a much larger intervention than just a day off from work or school, right? And her response was like, I don't know, let's say somebody has very high anxiety, right? So if somebody has very, very high anxiety, one could argue, and I would be one of those people, that taking a day off is counterproductive in defeating that anxiety, because anxiety grows from avoidance. When we avoid something that we're anxious about, that makes it more of a threat. It makes it scarier. So if I said to you that behind this, in here, in the cabinet here, there's something really scary that's moving around and is alive, right? You'd be like, oh my God, right? If you were to go look at it and see that it's a butterfly, right? So then your anxiety would change. But if you avoided it every single time you came here, you sat in that part of the back of the classroom, you tried to never come into this room, you're freaking out, so your avoidance would just confirm your belief that this is something which is going to kill me, per se, or whatever, something horrible. So I could make the argument that our current state of anxiety, and we'll talk about this in 2 weeks when we really talk about anxiety disorders, our current conversations around anxiety might actually be making anxiety worse. Right? So when we go back to your question, it's a good question. Like someone's drinking a ton of energy drinks. Doesn't that cause anxiety? Yes, it does. Is it the sole reason why the anxiety is there? I don't know yet. So you're going to note that for later. Okay? So note that for later. I'm going to refer back to this slide a lot because I'm just going to say that's a good thought. We might not have enough information yet, but note that for later. Right? Remember last week when we were looking at the video and I said I was looking at his eyebrows. Right? Remember I was talking about that? That's a note that for later, because I'm like, he's very expressive with his eyebrows. Maybe I can learn a lot from his eyebrows. So I'm going to note that for later. Not, he expresses everything through his eyebrows, and therefore, slow down, calm down. All right, so medical history, we talked about that. And now briefly, I want to talk about this here. Affect. All right, so this is complicated. What affect is, it's not really defined there. But affect is your general expression that comes with any situation. Okay, so meaning that your facial expression and your body language and you, right, is there's a certain expected affect that we expect it to look a certain way in certain situations, right? So like I talked about last week, my guy who was saying, I'm really angry all the time, right? His affect is not matching what he's saying, right? My wife's going to divorce me, right? It's part of the reason why masks are used in horror films, because a mask has no expression. And it's scary to see something have a blank expression while it's doing something horrible, right? It's off-putting. You know what I'm talking about when it's off-putting. When somebody's affect is not matching the situation, it's off-putting, right? So you have this scream, right? Scream is a lot more scary because the face is stuck like that, as opposed to seeing somebody who has evil in their eyes and is doing something evil. Like it's messed up. Messed up has no expression, right? Masks being, that being an example where the affect, that would be like no affect, right? And we're going to see later on in the semesters, there are certain times where no affect is indicative potentially of a more serious disorder, right? So if somebody's sitting there and you're asking about orientation, do you know what time it is? Do you know what day it is? Do you know why you're here? Right? And their answer to that is something like, my mom said that I should come here. Right? Okay, your mom said you should come here. Are you aware that this is residential treatment and that you're gonna be here for like at least 2 months? Yeah, my mom said that. I hope I can make it back for a basketball game that I have. Like, if any of us had to be somewhere for 2 months that we didn't choose to be there, we definitely wouldn't be flat affect, right? So affect is something that we look at to kind of understand their connection to the moment, their connection to the reality of the situation, and a connection to their own emotions, right? So if somebody's really angry and they have flat affect, that's very interesting. Why is that? Right? If somebody is very, very happy in a situation which it doesn't make sense for you to be that happy, right? So we might think something along the lines of there is elevated activity here which looks a lot like a mood disorder, right? When somebody is just elated for no reason, right? That's concerning. It's kind of off-putting, right? Now also, our affect could be inconsistent when we're using substances, which is a very, very important thing to consider when you're doing an assessment. Like, is this person on something right now? If you are assessing somebody who is on a substance that doesn't make it tremendously obvious that they are on that substance, so you got to look out for it. You got to kind of see it, right? You got to look at pupils. You got to look at speech. And the speech slurred a little bit, but is the speech slurred because that's how they speak, right? Or is the speech slurred because it's part of a constellation of behaviors that I'm observing and I'm thinking that it might be related to a substance? And in certain settings, you might ask that question straight out. When was the last time you used any mind-altering substances? Did you use before you came here, right? Sometimes you ask that question, and then this is where it gets really interesting in the assessment. Sometimes the way somebody answers a question tells you more than the actual answer to the question, right? And I feel like ladies, you guys understand this better than us men. Like we're kind of like, what, you answered the question? What are you talking about? And like, if you really loved me, you wouldn't have answered it like that. But that's because we are not as evolved as you guys. Sorry, men, but we're not. We're not as smart as you guys emotionally. So that kind of, we do our best. What do you mean? I got you flowers. Yeah, that's not how it works. Okay, fine. So we're going to talk about this a lot because this is a very, very complex concept. All right, so I just wanted to touch on it, but this is a very complex concept, and as you're going in your profession and you are observing people and assessing people, you get better at picking up on different affect and different nuances within the affect, and wondering why it didn't match in this situation, and not even necessarily to diagnose a major issue. But something that you'll see is that a lot of intake forms have a question about abuse, sexual abuse, physical abuse, things like that, right? And maybe some of you guys have had this in your internships, but everybody will eventually come across somebody who answers it very matter-of-factly with horrible information.
Mm-hmm.
Yes, I was raped from ages 3 to 6. That was a client that yes, I was raped from ages 3 to 6, and then my father beat us mercilessly until he left when I was 12 years old. So that's my abuse history. Right? So you might think you're getting a lot of really good information, which you are, but really the real information you're getting is that they're talking about it in a very disconnected way. Right? Meaning the affect is saying to you that the words they're saying have a different value because the affect is saying that they are not emotionally connecting to something horrible that happened to them repeatedly throughout their life. Right? So you might note that for later, right? But that's not even affect in terms of a diagnosis, that's just affect in terms of understanding the person, right? Because from there you might start to think, is this person really, really, really bottled up in their trauma, right? Talking about it in a matter-of-fact way when it's something that's horrible does not mean that you've overcome it. Definitely does not mean that you've overcome it. Most of the time what it means is that you are not ready to really explore the feelings that are there, which makes a lot of sense because it was horrible, whatever it is that we're talking about, right? So when you have those intake forms and you have to follow the form to fill out the form the way that the agency wants you to, you're going to see that kind of stuff happen, where you have to ask a really intense question and you get a very flat answer to a really, really complex and sometimes horrible situation that they were in. So we're going to come back to affect a lot. All right? Any questions or thoughts or anything?
So could it be if he already or she shared that story for 20 times before us, so they kind of relieved the emotions already, cried for 20 times, and we are the 21st?
It's an interesting question. Most of the time, if it's something really terrible, so people are not flat about it. Like I'm talking about flat, right? So if somebody would be like, well, my dad he was an alcoholic, he beat us daily until he left at 12, when I was 12. I had the whole incident with my babysitter from ages 3 to 6. She actually raped me a lot of times. Right? That's very different than somebody being like, I was raped from ages 3 to 6, and then my father beat us every single day, and then he left. Right? That's the difference in the affect, right? If it's flat.
So one is flat and the other one, what would you call it?
I don't know. I don't have a word for it. You can give it a word. But this is something that if you ever do trauma treatment, there's certain types of trauma modalities where you're really trying to observe micro expressions and movements that come up when they're talking about it. And those little movements are an indicator of which way you're going to go next a lot of times. Right? So sometimes you'll see somebody in the middle of being flat about something kind of go, and you might know the client, you might know what that kind of means, and then you might point it out to them depending on the modality and what you're trying to work on, but you might point it out because you became somewhat of an expert in their specific micro expressions, right? How it relates to their trauma. All right. What about people who lie when you're doing an assessment? So, you are not a detective. However, Dr. Gregory House taught us everybody lies. Do you agree that everyone lies?
Yes.
Yeah? Oh, that was easy. Does anybody think that people are capable of not lying? Do you think that we're lying at all times? That's easy.
Maybe if you're autistic.
Okay.
Yeah.
So, follow-up question. If everybody lies, so then how do you trust anything that anybody says? How do you know the difference? Like if you're meeting with a client and everything they say, you're going to be skeptical about everything they say? Every single thing they say?
You may look for patterns.
Okay, what do you mean? Patterns?
If you say you have a report from another medical practitioner and it's contradictory to what they're reporting, and you actually have the facts, but they're saying it's not true, but there's contradiction there.
Okay, so interesting. So you would look for a potential contradiction. However, just to be really annoying here, if you're thinking that everybody lies, so then your sources of contradiction could be lying too,
True.
right?
Yeah, it's true.
Just for the sake of being annoying. But this is a really, really hard thing for us to deal with, because since we're not detectives and we're trying to build an alliance with our client, and we also we're going into a profession here that pretty much believes that people are good, right? So you're not going to sit down and be like, "Where were you on the night of it?" Like, right? Like, cut the crap. You're not a detective. You're not a cop. That's how I used to tell my clients all the time. I'm not a cop. If you want to lie to me, you'll probably get away with it, right? Because I don't know. I'm more likely to believe people. But that also is not the end of it, because you can't just go with that. You can't just be like, "I believe everybody all the time." Yeah.
Couldn't it be more of like you're meeting them where they're at, but also knowing the truth? Like I work in treatment, so like I had a patient today tell me he works for Elon Musk.
Mm-hmm. Does he?
No, like, but you know what I mean? Like if that's what he's thinking, it's like, okay, like if that's where you are, then I'm gonna meet you where you're at, but I'm also gonna know.
Okay, so it sounds like you're talking about like delusions and hallucinations and like that kind of stuff.
Okay, I guess.
Is that what you're talking about there? Like,
just like saying like if this is what this person is reporting to me, I know that's not true, but this is what they're believing to be true, and I'm trying to meet them where they're at to get them the help that they need.
so okay, so it's very interesting, because in this being a very general question, if we bring it to specifically delusions and hallucinations, right? We can say that, sure, like I can go with that. I can go with the fact that this guy thinks he works for Elon Musk. Maybe. But you don't really, though, because you know that he doesn't, right?
So yeah, would that be helping him too, or hurting him if I go along with the illusion?
Right, so let's say he starts to say, "I got to get out of treatment in the next week and a half because the SpaceX launch, they need me there."
That's actually the exact conversation.
Oh, dang.
Yeah. It was an interesting day today.
I'm sure it was. I'm
Yeah.
sure it was. Right, so is that helpful? And then we're going to talk about this later in the semester when we talk about psychotic disorders, but like, is it helpful to argue? You don't work for Elon Musk. Is that going to get anywhere? Right? But when you're working in a setting like that, and you have people who are coming in and they're saying things that are based off of delusions and hallucinations, it can get very hard to know what's true and what's not true, and you can also become, in a way, kind of jaded, right? This happens with the substance abuse world too, and the addiction world too, right? Like the old saying is, how do you know when an addict's lying when their lips are moving? And I was always like, that's not fair. That's not fair, because then they're never set up for success, right? Like it doesn't matter how long they're in treatment for, they're lying. They're always lying, no matter what they're lying. But at the same time, if you think that they're never lying to you, then you are screwed, right? It's an interesting one. Yeah, we're gonna come back to it. Yeah, go ahead.
Yeah, I actually approach it opposite with clients. I believe they're telling the truth
Mhm.
and just sit with curiosity, because I don't know their truth. I
Mhm.
can assume their truth. And also I feel like culture plays a part in it, right? Like culturally something might not make sense to me, but it makes sense to them, so who am I to say that they're
Mhm.
not being truthful?
So let me ask you a question. You guys are getting it. I'm annoying. Let's say after meeting with, in the end of like the first session, the client says to you, "I just want to tell you, I've seen a lot of therapists before, psychologists before, and I feel the most comfortable with you. I just feel like you're easy to talk to, and I feel like you really get me." What do you think about that?
What's happened?
Yeah, okay.
Yeah, I think that's
So-
being manipulative.
Is that what you think when I say that?
Mm-hmm.
Yeah. But what if it's true? But what if it's manipulative?
I see that.
I'm
Meaning,
still
essentially, what I'm saying is like, it's great if we want to be, if we want to believe, we want to go with I believe you first, right? But there also is maybe a healthy skepticism. I don't know. I'm not saying that you have to become skeptical of everything, but one could argue that maybe you want to have some skepticism, because when we talk about everybody lying, that doesn't mean that everybody says that there's something they're not. It's that maybe people want to be viewed in a certain way, so they present themselves in a certain way, which may not be the whole story.
That usually comes up with word building for me.
Right, okay.
So I'm able to detect when you are being manipulated.
Yeah. And right, and so later on, so sometimes, and that's a good thing about to mention about noting things for later, and this would be more for like a practice discussion, but when you have something come up like that, you're not going to confront a client in the first session, because that will backfire and will go nowhere, but you might make note of it, of like, there might come a day where I might say to the client, like I said to a client yesterday, I was like, why are you flirting with me? He's like, what are you talking about? I was like, you came in and you said, I haven't seen you in so long, and it's so good to be back. And meanwhile, while I was out for the week, you went against every single one of my recommendations that I gave you before I left. So is it good to see me? Are you happy to be back? Why would you be happy if you don't value what I'm saying to you? So stop flirting with me and let's talk for real, right? That happens to be a client that I've been working with for 3 years, right? And we have been through it. And I noticed his flirting behaviors 3 years ago. Whenever I have somebody come into my office and compliment me on something that, my office is a very active place. There's guitars on the wall. I'm always changing stuff. There's whatever. It's fun. It's like I had a teenager come in once and say, I don't get it. Is it a therapy office or a music studio coffee shop? I was like, correct. So whenever I have a client come in and say, like, compliment something on my walls, like 80% of the time I'm like, what are you feeling towards me right now? What are you talking about? What am I feeling towards you? I don't know. This is your therapy session and you came in talking about me. It's pretty interesting. Oh, I was just complimenting your, I think that's a new guitar. Like, that's not a new guitar. It just was over there yesterday. So like, what's going on here? Well, basically what we get to was, the way we ended off last session, I've been obsessing about it, and I think that you're going to abandon me, so I want to, make you see me as somebody who makes you feel good. I'm like, now we can do some work. Did you have something you were going to say?
Oh no, I was gonna say how do you maybe if you have a client and they're always lying, maybe it's something deeper.
Yes.
Maybe you don't have to. I don't know how to explain it. I guess this is I feel like you would research and try to find out why they're always lying.
Yes. And so what you're bringing up, and is actually a little similar to what you bring up there, is that sometimes the behavior itself tells a story more than what it actually does, right? Meaning the guy that I'm talking about, I asked him why he's flirting with me, and he didn't take any of my recommendations. I generally don't care if people don't take my recommendations. I'm like, yeah, you live your life, and I have my thoughts, and you do you, whatever. But this guy comes in and says how much he loves my therapy and how much he thinks I'm a genius, right? So he was like, okay, fine, so I'll take your recommendation. I was like, no, you don't get it. I'm pointing out a pattern in your life, which is a dysfunctional pattern, right? Which makes you suffer, because when your wife gives you a recommendation, you egotistically, and I can talk to him like this because this is the way it's been, I say your ego comes in and decides whether it's valid or not. Why don't you listen to your wife one time without assessing it? The same way you don't listen to me, you also don't listen to her, and then you make 15 phone calls to a whole bunch of other people to get their opinions, and you don't listen to any of them, right? So I mean, like the fact that he didn't listen to my recommendation, that doesn't really matter. It's the fact that it represents, in my facts clusters theories, right? It represents something which I see as a pattern. I've seen it enough times, and my theory is, right, your your narcissistic tendencies make it that you cannot accept feedback from another person. And then I diagnosed him with narcissistic personality disorder, which is kind of what happened. But yeah, we had yeah.
My supervisor said, like, if when clients come to us and they'll ask us, like, why are you married, or are you married, or a question, he was like, we are supposed to ask us, like, why do you ask that? But he said there's four reasons of why people do things: for attention, sometimes approval, expectations, or stress. So he was like, it could be, just don't assume. Someone could just come to you. I mean, you have clients like that. They'll come to you like all the time, and they'll complain, but they just want attention.
Right. Right. And when you have a statement like, are you married, or things like that, right? If you listen to the way that it's said to you, you can if you really become an expert in paying attention to those little details, the whole communication, you can really understand that the function of this question, what it is, right? So like I less now, but for a long time people would say, how old are you, to me, right? Because I looked young, and people were like, either they were curious, right? Like, you're young and you're a therapist, okay, so like, how old are you? Sometimes people would be asking me that because they would be like, if I'm the same age as this guy, how the hell is this guy my therapist? Right? Or if I'm older than him, right? I once had a guy lecturing me, you don't know what it's like to be an alcoholic and be 55 years old and be crapping blood from drinking too much alcohol. And I was like, I never said I did, right? So when somebody says, how old are you? Sometimes I might say, let's talk about what's the purpose of that question, right? Sometimes I might say to somebody, I used to do this a lot when I was in treatment. I will give you one guess. If you get it right, I'll say yes. After that, I will say no to no matter what you say. And then they give their guess, and if it's wrong, I honestly do that with them. If it's wrong, then I'll be like, nope. And then they're like, 31, nope. 38, nope. 55, nope. I just keep saying no. Keep saying no, because that's what I told them. And then there are other times when somebody says, how old are you? And I'm like, would you stop? Michael, could you stop? Just go, where are you supposed to be right? So like, depends on your rapport with the client, and it depends on your personal style, right? I use a lot of humor with my clients, but that also was something that took a long time for me to figure out exactly how to do it, because I did not want to be sarcastic and mean, right? And so like, sometimes it could come off as, you're being dismissive of somebody. And you can never be perfect with anything, because even if you want to be the nice person all the time, sometimes being nice is an inappropriate reaction, right? If somebody's like really excited about something, and you're like, wow, that's so nice, I'm so happy for you. Like, sometimes you just be a human person, you're like, that's freaking awesome, right? But if you want to play it safe all the time, sometimes playing it safe actually ends up backfiring a little bit, sometimes. In terms of lying, right? Sometimes it could be a part of a larger pattern. It could be a part of something pathological, right? What's the function of this? Why is this person telling me something that's not true? Is it something that benefits them to tell me, or is it something that they're actually just doing because it's a part of the way they live? Right? Like, I've had addicts talk to me about this, where they say that they will lie for absolutely no reason, because it's a part of their life. And they will catch themselves, when they're later on in their recovery, catch themselves lying about something which has no benefit at all. Like, they'll call me and they're like, hey, I'm running 10 minutes late, I'm just getting on the 95 now, right? And really they're in their driveway.
But why do they do that? Why do they lie?
So what would you say?
It's a learned behavior, so maybe when they were younger, it worked for them when they were younger, and they developed that pattern of, okay, I get my way, or I get out of trouble if I lie, and so then it becomes something that's really unconscious, and they just do it.
So it could be. I want to direct you towards the immediate benefit of the behavior. Think about that, right? Because there's always levels. There's always levels to everything that we do in terms of the benefit that we get from it. Primary gain, secondary gain, tertiary gain, right? So if somebody were like, let's say, every once in a while, I will get a coffee roll from Dunkin' Donuts, right? That's not healthy for me. I like it, so I do it, right? if I said the reason why I did it is because I like coffee rolls, and that's the whole story, that's not true. That's not true, because if you really think about it, the day that I get a coffee roll is probably a day where I'm pretty stressed out, right? And then that pastry is providing me with some comfort on the secondary level, right? So meaning if you think about it from like here and now, what's the benefit, right? Because sometimes we want to ask the question of like, why is it here? And we want to go back into the history. And we want to be like, you know, what in your life made you function this way, right? Which is very valid. But then there are also times where understanding the behavior that's presented in front of us right now is going to help us conceptualize this person. Like, why would you do that in this moment? Right? Why would I get a coffee roll today at 4:15? Right? When yesterday I drove by the same Dunkin' Donuts. Right? And I was like, I am a healthy person. Right? And today I was like, oh, I'm getting whatever I want. Right? You were going to say something more?
Yeah, I was just going to say, you said that it starts as something that they use to protect their addiction and then develops into a pattern or like a way of life for them.
Right. So okay. So when you have, so this is good conceptualization here, right? Like if you are doing something in your world which you know the people around you and maybe larger society would frown upon it and try to stop you from doing it, right? But you like it. So then you decide you're going to go ahead and do it. You got to conceal it, right? Because if your wife sees you doing lines of cocaine, she's going to be like, "What the hell?" Right? So you try to hide it, and then when you try to hide stuff, you have to concoct some stories to protect. You know, it's not just one piece of your life. I tell this to my clients all the time. It's like if you had a mansion with a safe inside that mansion in a locked room, and in that safe was the most important thing to you in the entire world, and I said, hey, can I park my car in your driveway overnight because I just need somewhere to keep it, you would be like, no. Because it's too close. Like, meaning you start to build walls around walls depending on how serious it would be if you got caught with that thing. And then you might not even realize why you're building those walls anymore, right? So that's where the compulsive lying with addiction comes in a lot of times, where it's like I'm so in the habit of lying that I don't even realize that there's a purpose for it anymore. It's kind of like biting my nails. Like I'm biting my nails and I don't realize I'm biting my nails because I'm just doing it, right? Like I do it so compulsively, and that's where, like, you know, somebody with a compulsive lying pattern that's associated with an addiction might not even realize that they're lying, you know. Which, again, if you're working with people in treatment and you're assessing them, right, and they say, I haven't used any drugs for 3 weeks, but in their mind, marijuana is not a drug, right? That's kind of tricky stuff, like when you're assessing somebody and they're lying. Yeah. Yeah.
In a case like that, I mean, you could drug test the client and then you have that. You are positive for this.
What about when a client says to you, it's got to be a false positive. You know me. You know me. I've been clean,
Let's
right?
do it again.
Let's do it again.
If it's a false positive, probably won't happen twice.
But I can't pee right now. I just peed. I just peed like this is a bunch of years ago. I used to work in a facility. It was an outpatient facility, but they drug tested in the facility, and with the male clients, actually it was mostly male clients there. Well, the males worked to the males, the females worked to the females. We had to be in the bathroom when they were giving the sample, right? And so this guy was like, he was like, I was like, actually, I gotta keep the door open. He's like, what do you think I'm gonna do? I was like, listen, it's just like the policy. He's like, don't believe me, just watch. That's great. When it comes to people lying, this is a very, very complicated thing, and so lying is a harsh kind of word, but think about it like everybody wants to present themselves a certain way, and you learn a lot about what people choose to present to you and how they choose to present it to you. I work with a lot of men who come into treatment because their wife made them come into treatment, and they will try to make their wife sound like a devil woman in the first session. Or they will make themselves sound like the greatest husband that ever existed, who just happened to accidentally 1 or 2 times cheat on her with a bunch of hookers. It's like, it's not like I'm good on my wife's amazing. My wife's amazing. Okay? She can do anything. She's the best. I love her to pieces. Oh, so why are you here? My wife's making me come here. Why? Because I cheated on her a bunch of times. Oh, she's that amazing that you cheated on her, right? So people present what they want you to see. And that doesn't mean that they're lying in the sense of like, I gotta catch you in a lie. It's more to say, interesting. That's what they want me to see. Why would they want me to see that? What do they benefit? What's the function of this behavior, right? You have people come into treatment or into therapy or whatever looking like they don't need it, right? And it's like, well, then why are you here, right? Kind of talked about this a little bit before, but insight into the problem, right? If somebody is in treatment and you're saying, do you know why you're here? And they're like, because I play too much video games. Yes, but like, you don't have a job and you stay up for 3 days straight and you have a meltdown every time the screen goes off, whatever, right? Mm-hmm. Meaning, do you have a real understanding of what's happening here, or are you limited in your insight? And limited in your insight is interesting, it's significant, it's noteworthy, right? Most of the things during an assessment that we are pointing out are interesting. We're just kind of like, so you don't really see it that way, right? I've always been very skeptical, not always, after going around the block a bunch of times, working in treatment and getting burned by clients, and, I became very skeptical of clients who come in complaining about their last treatment episode, right? When you complain about your last treatment episode, so what are you trying to tell me, right? What are you trying to tell me? What's the function of this? What are you trying to present to me, right? Maybe you're showing me that you don't have so much insight into the severity of your issues. Because generally, if you go to treatment and then you are in another place for treatment, it's probably a pretty serious issue which is unresolved, and it probably wasn't just because the last place was really mean to you. So when we talk about insight into a problem, this is very, very interesting and very, very important. What does it seem like their conceptualization of the problem is, the severity of the problem is, right? The need for intervention, and this is where I'm going to jump some slides over here to what is their motivation for actually doing treatment, right? Like, think about this. Anybody who comes into any form of mental health service at all, as an adult, has likely suffered with the problem that they're bringing to you for many years before this moment. Right? Unless it's something recent that happened, like there was a tragedy, a trauma, grief, something like that, right? But most of the time, people coming in to deal with a problem have had that problem for many years and have tried to deal with it on their own and were unsuccessful. Right? That makes sense. We all have problems all the time. And then we try to solve it on our own, and if we can't solve it on our own, we ask somebody for help. And if we ask somebody, like a friend of ours, for help, and if it doesn't work then, maybe we try to come up with a new thing, right? If you're like, I want to eat healthier, right? So one day you throw out all the cookies and ice cream from your house, and another day you sign up for Noom, and another day, right? Like, you try a lot of things. When does it reach a crisis to the point where you are like, I am going to hire a professional to intervene on this? Right? And that's where one of the most important questions comes in. And if there was a test, this would be an answer on the test. Why now? If you're 48 years old and you've been drinking since you were 16, why are you coming in today and saying, I have a problem? Right? If you are 55 years old and you have had anxiety your entire life, why are you coming in now and saying, I need help with my anxiety? And in cases where there's a severe issue, why didn't you deal with this a long time ago? Right? Like, I will work with a lot of older men that have been watching porn since the internet was invented. Right? And before that, they were walking in Times Square, doing the magazine thing and doing the video stores and whatever, right? So why now? In a lot of those cases, it's because my wife just caught me. Right? In cases with emotional dysregulation, well, it's because I had an outburst at work and I got fired. Or they're going to fire me. Right? My spouse is going to divorce me. These are things that motivate somebody to come into treatment. Now, that question is so important because going to where the client is at, right? That usually means where they're motivated, right? Because it could be very confusing, that idea, right? Like where the client is at. I had a professor that said, if your client wants to walk on the sun, then you help him walk on the sun. And we're like, what the hell does that even mean, though? Like, how would we help him walk on the sun, right? I mean, good guy. I don't agree with him necessarily because I'm kind of like, go to where the client's at means like, what do they want to work on? What are they willing to work on? Where's the motivation to do something, right? So sometimes you'll have a client where the only motivation that they have is to show up so that this other person doesn't say, why don't you go to therapy? Like this happens a lot if you work with teenagers, right? I'm here because my mom makes me come here, right? And that's pretty valid if you think about it. I mean, if you don't want to go at all and you don't have any insight into the problem and you don't believe that this is going to be a helpful intervention, so then why would you be like, I'm here to work on my depression? You're not going to be. You're going to be like, I'm here so I don't get fined, which was another thing that a client said to me, which I don't know if you guys remember Marshawn Lynch saying that, right? You guys remember that? No? He said that in football player. He said that in a press conference. He didn't show up to the press conference. He got fined. So then the next week, every time they asked him a question, his answer was, I'm just here so I don't get fined. And then they would say, what do you think about the game today? I'm just here so I don't get fined. Right? So I had a client say that, a kid say that to me. He's like, I asked him a question, like, what'd you do this week? He's like, I'm just here so I don't get fined. I'm like, that's awesome. That's awesome. Right? But it's very real. And so when you ask this question, right, you can learn so much about a person and the way that they think and the way that they operate by the way that they answer the question, what they answer the question, and the way that they answer the question. Right? I'm here because my wife is making me. I'm here because my marriage is falling apart. Those are two very different answers, right? But even, I'm here because my marriage is falling apart, I don't know. Like, do you really feel that? Or are you kind of like saying that because you know that's what needs to be said in this type of situation? Because I have that all the time. I'm here because my marriage is falling apart. I got to save my marriage. And then I'm like, cool. Okay, so would you like to schedule another appointment? Could we meet every other week? So your marriage is falling apart, but like not enough that you would like do therapy, right? It's very interesting. Why now? It leads us into the motivation. This is going to be our last slide before our break here. Some of you guys have heard about this. A lot of times it's talked about in the substance abuse world, but it applies everywhere. Internal and external motivation is a really good way of gauging where somebody's at in terms of their insight. So internal motivation is, this is something which is valuable to me, and I'm going to do this regardless of external factors around me changing, right? So like I tell my clients all the time, if your motivation is external and you're saying that I want to be sober so my wife is not mad at me or so that she doesn't catch me, guess what happens when your wife goes on a trip? Your motivation goes on a plane too. And then she comes back and you're like, oh yeah, oops. Right? As opposed to imagining that you had the ability to act out or lie or whatever and nobody was going to catch you. What would be your reason for not doing it? Right? So when you see somebody coming in and there's external motivation, again, that could just be a reality. That could be fine. Meaning you don't have to say like, oh, well, they're not motivated because they don't have a high... No, this is where they're at, right? And there's a reason for that. Now I'm going to work with them where they're at. And it's the same thing with internal motivation too. is, there's the, okay, let me build off of that internal motivation, or let me test that internal motivation, or let me see from week to week what that internal motivation looks like, right? Because sometimes things look like internal motivation, but they're really just, they're selling you something, right? That's why on my notes I had that client I told you about last week where I was looking back on my notes and it said, God, 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 blah, blah, blah. Because he was trying to convince me how religious he was. And I was like, I don't care how religious, like, I don't get anything out of you being religious. It doesn't do anything for me. So clearly this does something for you, right? And so like the internal motivation actually turned out to be more externally motivated because he was trying to sell me something. So don't forget this question. Don't forget why now. Because it's probably also not on a lot of intake forms. It's not an official question, right? It's not a question that the treatment center or insurances want data on, right? But this is a question for you in conceptualizing the client, right? So when you go back to the facts, clusters, theories, right? Part of your theory could be motivated by their answer to this why now question, right? Like the way that they answered it indicates a more severe issue. It indicates that there's something here which doesn't add up, right? It indicates a lack of insight, a lack of motivation in a very serious situation. That's interesting. Make note of that.